one other kind of just pro tip out there for all of you agents listening. When you do call into the marketplace, what?
You're going to say this? That's the best. That's the best stuff.
You know what? I
all right. Okay, brother, you share the goods of the goods.
I am giving you all a very good pro tip out there for free.
This is secret nuggets.
Okay. This is the big deal that we've even discovered even the last couple of weeks. It wasn't heavily advertised, but when you call into a marketplace.
Yeah, I'm just wanting to hold back the best 2 or 3%. Those are the gold nuggets. You owe us. You should move your ACA business over to us just right there for sharing those kind of nuggets.
Agent Boost.
Starting it off, hey, it's November 26th. It's today we're shooting. Big news today. The CMS call letter dropped either this morning or last night. I can't remember. But my phone, all my alerts were bombarded by 6 o'clock this morning, and I was already half groggy this morning, rolling over in bed, looking at all the alerts and starting to read about the call letter today. That was my day. So anyways, obviously I'm going to preface that with that's what we're kind of going to dig into a little bit today. But before we get into the nitty-gritty details of the new call letter for 2026, we probably ought to spend a few minutes and kind of recap a couple other themes going on in the industry right now. Start off with maybe
we were right. We got a call letter.
Hey, by the way,
we were a couple days late, a week late.
I was predicting it right near around the election time, so I was off by only about 2 weeks.
I thought they would have dropped it tomorrow, just the day before Thanksgiving, but.
Yeah, but no February, no March date. I was right. My sources were right. Just delayed it by a week or two, but.
And hey, but good news was this one was only 700 and something pages as opposed to 1,300. So we got a little bit of a break.
Now, this is the current administration call letter, so I'm sure we're going to have, red lines, like I said, to oblivion.
They just crumple it up and
throw it away.
Throw it away. Yeah. We'll see, but
the real business is going to happen come February and March, in my opinion. But before we dig into everything with the call letter, two elements that we wanted to kind of recap really quick is this last week. There was a lawsuit out there for those of you who are following lawsuits in our industry. United Healthcare had sued CMS, and actually they were victorious in their lawsuit. It was for basically
overly punitive
harming their reimbursement payments for STARS metrics, and a lot of it, same themes with like the Centene and the Humana lawsuits, is that they were basing decisions off of very limited data, like one phone call or a handful of phone calls, and having way punitive damages to the tunes of like $70 million in negative or lost revenue.
Yeah, and this one was centered around that one. There was one call that, needed some translation services that CMS overly weighted, and it kind of became an inflection point for a really bad example of being overly punitive for one specific call and having disproportionate financial
effects from it.
Effects from one call and not a pattern of behavior.
Anyways, they won that lawsuit, and of course, it's already been communicated that there's not as many punitive.
Has CMS won any lawsuits?
I'm keeping track, and so far, I think they get a goose egg for this year. I don't think they've won any lawsuits in calendar year 2024.
I'm going to do some research and see what their track record is for having their.
Hey, maybe if we're wrong, please comment on our podcast. You can comment on YouTube, aka the Censor Police, and you can put on our page whether or not we were right or wrong. But I don't think they've won any lawsuits this year. So
yeah, it'll be interesting to dig in and check on that.
So that was one thing we wanted to mention really quick. And then the other thing was we've been having a lot of conversations just because we're in the heat of open enrollment, OE, for, ACA or marketplace enrollment season. And, for those of you who are selling, of course, anything you're writing right now up until December 15th is going to go into effect January 1st. Anything you're writing after that is going to go into effect February 1st. But we're kind of in the heart of open enrollment. And one of the big trends is that all the carriers, for the most part, way over forecasted or over projected what they thought they were going to get in enrollments. We've been banging the drum and saying, hey, there's been so much fraud. It's going to be way less. But nonetheless, the numbers that they all forecasted were crazy high. And now we're having a lot of carriers who are scrambling that are trending to hit 30, 40, 50, 60% of what they were maybe forecasting initially for enrollment data. And overall, the marketplace or ACA enrollments are way, way down from last year to this year.
Yeah, so. I've been reading a lot. We've been digging into this behind the scenes, and I'm a little bit surprised and a little bit annoyed that some of the carriers were this far off of their projections and kind of like what their goals and their expectations were, because they lived through the same chaos that we did last year. And so I really don't get how all of these, this leadership at a lot of these ACA carriers nationwide were like, yeah, we had so many enrollments. There was all these factors last year, and, all these enrollments, I say enrollments, not necessarily, good, legitimate lives, but all the carriers, it seemed like, they did what public companies do. And they're like, oh, more. What did we do last year? Okay, let's do this. Let's do more.
Well, to the tune that some carriers are projecting a 25% net overall increase of their entire membership nationwide. They're going to say, hey, cumulatively over 10 or 15 or 20 years, we've accumulated X amount of membership. We're going to grow it by 25% in 1 year. I mean, that's just way overshot as far as like a projection.
Well, what's weird to me though, Dan, is that we've sat and experienced this whole ecosystem of the ACA and the disruption this year, and we've talked about it at length all throughout the year, and we've made adjustments to do things in a smarter, healthier, sustainable way to be compliant with, we've always been compliant, but to make sure that we're, following whatever the latest whim of CMS and the enrollment mechanisms are. And so we've had to really retool and adjust our expectations. And I'm just really surprised that a lot of these carriers didn't go through the same exercise. I mean, it's like we had the big, massive event this year that already wrapped up. We had a lot of headwinds going into this. And I'm just really surprised that so many of these national leaderships thought that it was just all going to be green lights and that they were just going to go gangbusters like they did last year.
Well, and I would also add to that too. We've said it 2 or 3 times again. I'm sorry if I'm redundant and I repeat myself. I don't mean to. And it's one of my biggest pet peeves with myself. I hate when I repeat myself. But I will say that we've been telling carriers as well that things just take longer in order to process an enrollment. Like we're at a stage where we've always been, where we're trying to go through an actual sales process with people on the phone or in person, where you're having to find out about their docs, their meds, where they're accessing care, do they understand their deductibles, any other exposures. When you're really doing that good presentation, and then on top of that, you're having to really call into the marketplace, wait on hold, and actually do the enrollment, it's taking significantly longer than just being like, hey, I got your information here from this final expense or mortgage protection, and I'm going to claim you, and you're yep, there's an enrollment. It's taking significantly longer. So from a bandwidth perspective, people just don't have the same capacities that they've had to in the past. And I'm not saying our organization, I would really tell anybody, we have always done it the right way. But when these other agencies and other agents in the space are having to pivot and change their processes to more of a compliant manner, their capacity is just going to be delimited, or is just going to be limited.
Yeah, there's just a logistical operational component to it too, because like Dan's saying, a lot of these enrollments that were done last year were done by call centers, whether they were doing it the right way or not, but they were able to get through enrollments in a few minutes. I mean, a lot of them were just getting through the basics, slamming, buying another call back to back to back. And you had agents that were able to process 40, 50, 60, 70 apps a day going crazy. And now there's just a logistical component too, where, calling into CMS, which you have to do, and that you wait on hold and then you go through that call, it's taking even a productive compliant agent 5 to 6 times longer. So there's just and
one other thing too that I want to bring up to that equation from a sales process perspective, and hopefully any regulators, people at carriers can appreciate this now, because of the way the carriers are trying to align compensation and incentives for the broker community, where a lot more of the bonuses are focused around retention and renewing your book of business. and also around silver and gold kind of metaled plans. And so again, in the past, it was like, I'm just going to do the safe thing and throw everybody on a bronze. And we saw a lot of sloppy work in the industry in general, where it was just, you had their information, you pitched a bronze, you put them on a bronze, that was it. Now, where bonuses are tied, a lot of carriers, not all, a lot of them are paying only on silver or gold tiers or silver or higher. Well, so now that those brokers are having to have more in-depth conversations with their clients to try to see if they can get them onto a premium type plan. And so that's taking a lot more work in that sales process. So that's, that one thing that's really going on, which actually is a very good thing that I think, carriers should have a little bit more sympathy and understanding as far as the numbers going.
Yeah, so. I think too, we know a lot of our big Medicare FMOs and these entities that were jumping headfirst into.
Oh, and before I forget, that was my other point. The renewal too is we're talking to a lot of agents now who the renewal process, is taking a lot longer than last year, because last year you could just do a few clicks and renew somebody. And all of our brokers and in the industry, what you're seeing is those good agents don't have the sales capacity to write new business, because for them to do a good job of going through their book of business and renewing their clients, they're having to call the marketplace when it's like, hey, this particular plan is no longer available. I want to move you to a similar type of bronze plan. And they're having to get on the phone with marketplace. Renewing their book of business is taking significantly longer. So they therefore are not selling as many new plans. So that was the other component that I wanted to mention before I forgot.
Yeah, Sorry. It's been that's a good point. It's been a massive log jam, because we have a lot of great agents, some of the best agents in the country, that have massive books of ACA business, hundreds or thousands of clients on the books that they've been able to manage themselves or with an admin or something like that. And this year, they've just been drowning in being able to keep as many of the policies and renew their people, and they haven't been able to focus. Even still, we're at, halfway through OE already, and they haven't even been able to shift their focus into acquiring new business.
They haven't sold a new plan.
Because they're still trying to keep and service the clients that they've had. So just a really, just victim of the circumstances that we'd created this year. But I wanted to also talk about a lot of the FMOs and big national entities that have a lot of bandwidth and infrastructure really got wooed into the ACA space last year, a little bit after we jumped in full force, but it was like this gold rush. And then with all the chaos that's happened this year, you've seen a lot of those entities. I think they've pretty much just said, to heck with it, and they've had to basically worry about all the Medicare SARs and the Medicare obligations. And just when they were getting the gears of war going to shift into ACA full time, you've had all these headwinds, and they're kind of, I don't want to say exiting the space, but they're not focusing on it like they were before. And they're also thinking that, we're going to maybe reemerge into another good era of Medicare over the next 4 years. And so they're just kind of going, it seemed nice and fancy, but I'm glad I didn't, fully jump in, and I'm going to focus my resources elsewhere. And so I think you have major distribution arms that are, that carriers were expecting to do a lot of volume, that are just frankly not going to do it this year.
Yeah, I think they had great intentions that was their backup plan, or where they were going to pivot to if things got hairy. And now that they're determining that it's not going to be as bad as anticipated, that they're not going to have to go through all the pain of doing that. And so I think they fall back to what's easy and most convenient. To kind of wrap up on at least ACA for now and for this episode, one other kind of just pro tip out there for all of you agents listening: when you do call into the marketplace, you're
going to say this? That's the best. That's the best stuff.
You know what? I
all right. Okay, brother, you share the goods of the goods.
I am giving you all a very good pro tip out there for free.
This is secret nuggets.
Okay. This is the big deal that we've even discovered even the last couple of weeks. It wasn't heavily advertised, but when you call into a marketplace, and I'm going to use this very specific example, we have a very, very good high caliber agent who sells a lot, both Medicare and ACA. And when they called in on one of their enrollments, even this last week, it was discovered that 25 individuals or entities had access or consent to make changes on their marketplace account. Just think about that for a minute. 25 different entities that all had the ability to change or move their coverage into different plans. So when you call into the marketplace right now, you can make sure that if you're on the phone with the client, that you can revoke all others' access and consent to your account. So that is, again, Mike is a little shocked that I'm telling you all really good applicable industry advice. But
hey, yeah, I'm just wanting to hold back the best 2 or 3%. But hey, those are the gold nuggets. You owe us. You guys, you should move your ACA business over to us just right there for sharing those kind of nuggets. But yeah.
So just think about as you're going through even your own book of business and you're calling the marketplace to do a plan change, you should, while you have the client on the phone, check to see who has access to that client or customer's file or account, and if who else has consent. And you should, with your client on the phone, get them to revoke all the other consents. So it's just you as their
I'm just
agent.
going to say, if CMS actually allows for 25 different placeholders to have consent to something like that, that's just stupid. And that's just absolutely ridiculous from a back end process that would even be, that would be any sort of intelligent organization or management of that individual's healthcare, because that's just ridiculous.
So think about it. So let's say 20 of those 25 people follow all the rules and they do everything they're supposed to, and 5 don't. You still have 5 shady SOBs out there, or call centers, or agents rolling up over, a principal override that are going to plan change and flip them from, Ambetter bronze to Ambetter silver, and then the next person's going to go, I'm going to flip them to UHC, and then the next one's going to, flip them to, Blue Cross of Texas or whatever, and they're all just going to move them around to whatever pays them a commission, right, without even talking to the customer again. So, anyways, that's a big.
One positive thing that Health Sherpa announced, the active consent you can send out to your clients, and that reminds me, to that point, we should check with Health Sherpa and see, does that mean that multiple people can have active consent, or is that overriding or stripping out the other individuals? Because if so, that seems to just be possibly exacerbating that problem. So our friends at Health Sherpa, if you're listening, hit us up before I hit you up, because we're gonna want to know the answer. Because
just like everything, you want to almost like make it to where it's like a credit freeze, where you're just like, this person and myself, we're the 2 authorized parties that can make changes, and outside of these people,
let me just help you out, CMS. In Medicare, we have marks. You have your MBI, and we all know that only one MA plan or PDP can occupy that slot at any given time.
Yep.
It seems incredulous that the same entity would regulate that and let there be placeholders for multiple people to have all these different, access to make plan changes for those beneficiaries, because it just creates this chaotic system. So we definitely just need to, update the placeholders, or the amount of like people that can have access to that with permission. Because like Dan said, it's like giving people access to your credit information that can sit and ping your thing and make all these changes and add stuff to your file. It should be, very, very judicious on who has legal permission and access to be able to make those changes.
Well, and let's just, even from that perspective, let's just play devil's advocate and say that everything was done in good faith, right? Let's just pretend that, a person talked to broker Mike, back on, November 10th, and talked about a particular company or product and got consent, and broker Mike signed them up on this particular plan and did an enrollment. And then, December 13th, talked to a different broker who has consent and did the same thing, and essentially decided on a different plan or product, and they're changing. And you're constantly seeing in platforms and system these 2 brokers that are, or entities who are fighting back and forth, making changes. And broker Mike, the first one, was thinking like, I talked to this person. I actually had them on the phone. We discussed this particular coverage option. This is what they wanted. They selected it. Damn it. Why is this fraudster over here changing their plan to another one? I'm going to change it back. And then the other person's like, I just talked to this person. This other person's scamming me. And then they're both just going in the system and making 10, 15 different changes, fighting over that same person who they both spoke to. So even in those cases where there's not necessarily fraud that's occurring, it can be quite a mess. And hopefully that example is portrayed to, carriers and regulators out there, so they understand the problem with having multiple people having consent.
Yeah, there has to be a mechanism where it's the revocation of prior consent type of thing, just like there is in the Medicare space. I mean, the same thing kind of does happen in Medicare, if you have competing agents, and a lot of times there are beneficiaries that have talked to multiple people.
But a lot of times that beneficiary will have to call in and back out the app themselves.
Correct.
Or,
it only allows for one thing to be pended in there. And, if you're a smart agent and you go in and you look and somebody else changed your plan behind and their client's saying that they didn't do it, it's pretty safe to say that was, done fraudulently. But a lot of times buyers are liars.
Yeah, exactly. They don't want to tell the agent I just threw away your card or forgot or didn't care. And
every agent that's done a decent amount of business has had another agent that thinks that they're frauding them. I remember one time we had a United Healthcare rep in our office, and another agent called me and was like, "You're frauding my client." And I'm like, "Your client did a full recorded conversation. I've actually got the United Healthcare rep here in my office. I'm going to go call you for I'm going to get you termed for harassing me." And that agent backed down pretty quick. But I'm like, your client that lied to you did a full telephonic enrollment. I have a recorded conversation and signed an e-app. So your client might have lied to you, buddy, but wasn't lying to me.
Yeah, exactly. So those are just things on the ACA. Anything else we should cover before we get into the call letter?
No, I think it's good to know that we haven't read all 700 pages yet, but we will. One of my friends was just asking me if we just have ChatGPT summarize it, and I'm like, kinda, but then we also have to read through every jot and tittle and make sure we find all the details.
Yeah, let's talk about that before we do, and I want to get into it. And two things. I actually, before the call letter dropped today, just so everyone knows, I had a different episode in mind that I'm still going to try to shoot maybe by Friday or next week, but I really want to do an episode going through the year-end planning process, like how you as an agent or agency should really close out your year-end and look back on your achievements and objectives and goal setting and criteria for the year, and then map out and kind of do your SWOT analysis and go through your next year and how to really business plan and forecast. So I think I'll still do that episode where same thing that you can listen and get a takeaway. But that one got thrown on the back burner because of the call letter dropping. Like I said, and I'll be honest, there's episodes of the podcast where I'm dialed in, I'm in the zone, I'm really on point those days, and there's other podcast episodes where I'm packing it in, so to speak. But I will say today, I've been on all cylinders, a little fired up about some of this stuff from the call letter.
Let me just chime in on what you were going to talk about, because I think it's important to know that we've already done our end of year planning, and we're basically we already had our all hands company meeting last week where we reviewed our 2024 goals and kind of shared with our whole staff where we landed on everything and kind of unveiled our business plan for 2025. And now we're meeting with our departments individually and setting goals and basically building forth, the plan to execute on that. And it's important, I think, to let other entities and agencies, but also agents know that now's the time to do those things, right? When you do it now and you have a plan early and you're able to execute, you go into the new year already firing on all cylinders, because especially in this industry, it tends to kind of die off after annual enrollment ends and everybody goes into the holiday malaise, but it's also the end of the year. And It's very easy to just let a whole month of the year go by without effective growth or business planning or even longer, because then it takes a lot of agents and agencies till mid-January to get going again. And so avoid that pitfall. You should be making those changes, not just in your goals professionally. We'll get into that, but
you went longer, but the whole thing is time is currency, and it's a currency you don't realize. And if you're not prepped, like to Mike's point, you're going to finish AEP, you're going to loaf and be lazy throughout the rest of December. Plus, you don't really come back to work until mid to end of January. You literally lose 8 to 10% of your productive year not being, and it hurts. And so, anyways, to Mike's point, we're already done.
We'll go in that in detail, because I think that's great content for people.
Yeah, we're way ahead on that already. We already know where we're going to land, where we're going to end our year. We already have pretty good forecasts for all of our carrier partners to know how we're closing out the year. And we're already, again, focusing on achieving our objectives for next year. So anyways, I've been on all cylinders. A lot of mornings I wake up and I'm 30 minutes to an hour before I really feel like I'm awake and ready for the day. And today I was up and I was texting people at 6.
Yeah, I think you text me that like at 7.
I had already been reading for a while. Yeah, so I've been reading some of this stuff. And just, again, full context, next week I'll have read all 714 pages. Right now I have read the executive summary, gone through, took notes on my initial thoughts and my initial analysis on it, and then also started reading. I read about 25 pages about the vaccines, and that's about as far as I got into the call letter today so far. But again, these are just my thoughts. So, and to people listening, I really want you to understand that I try to play pretty neutral, and I've been in this industry for 17 years, and I've really lived and experienced through,
Be careful with the words you say.
I know.
The overlords will not like
I'm going
it.
to speak in code. Certain
donkeys?
types of leadership and other types of leadership that changes every 4 years. And I've experienced a lot of different leadership changes at CMS and at HHS. And I will say that you definitely feel different tones and different goals and objectives that each leadership wants to achieve during their time there. And I've really have perspective now that I have gray hair and I've been around long enough to kind of live through it all. And anyways, we've survived all of it, right? And it's been okay. And it'll feel a lot different. But anyways, on this call letter too, I will tell you that I think the majority of this, or at least 50%, if not 80 or 90% of this, is going to just be crumpled up and thrown in the trash, so
Disregarded,
to speak.
yep.
Yeah, just because, again, going back to, if you think about how things have historically been done on a call letter, usually in all the years past, it was around February or March when CMS or HHS came and presented this call letter to all the different payers and providers and everybody and set the tone for the upcoming year. And it wasn't until, basically a year ago till last November to where they dropped it months ahead of time and really are kind of making more of an attempt to get 5 bites at the apple instead of 4, if you understand what I'm saying, and to try to squeeze in one more year of changes. So that's new, just in these last 2 years.
I sure hope that a lot of it gets tossed out. Otherwise, we're going to have hour and 30-minute long enrollments, and you're going to basically be reading disclosure statements till everybody glosses over and more red tape and hoops to jump through to the point where you can't even believe it.
Well, and my bigger thing too that I always, I want to go through and break down some of the things that I've already analyzed, but my bigger thing that I think is so tone deaf, again, going back to these changes that are being proposed, a lot of them, big institutions and big organizations can handle those a lot easier because they have big legal departments, they have a lot of compliance staff, they have people who literally read and break down and codify every little part of it and know how to go to market with it and remain compliant and teach their sales agents how to do it. But if you're like a solo agent out there who's just on their own, and maybe you have an upline or an agency or an FMO, and maybe they're involved or not involved in what you're doing, I mean, for those people to try to go through all the maze of all these proposed changes and everything and be able to do it and do it well, it's next to impossible, and they have a really hard time. So I think, like always,
well, let's talk about the last year or two of the call letters, all the details of it. We haven't even ingested 60% of that yet, 75% of that into the downline ecosystem of the Medicare Advantage and the carriers and things like that. And yet here we are with another 700 pages of proposed,
and I would just say
updates and changes.
Even this for context, and this is me living on planet Earth, talking to a lot of people. We are still having agents and brokers and agencies now, even crawling out of the woodworks and saying, hey, I know I should have been doing this, or I'm supposed to be doing this with the scope of appointment or call recordings. That was from the call letter 2023, I think. That was from 2 years ago. And we do have agents and agencies that are out there in the space who are basically admitting and saying, it's been a challenge for me to implement this in my business practices, and I'm still trying to do it. I want to do it. I have good intentions to. I want to be compliant. I'm not trying to be shiesty or operate in the gray. I just need help with it, right? And so to understand that that's where the industry is at, you just can't move at this fast of a pace even though you want to. And so that's just where I'll kind of set from to preface this. So a couple of the things that I wanted to go through, at least I read on the executive summary, there were basically 17 points. And I would tell any broker, agency, anybody out there, the executive summary is only a couple of pages. I think maybe 10, 12 pages, something like that.
3.
3?
4.
4. Okay. You're all salespeople. You all have ADD. I get it, but you can read 4 pages. I would encourage everybody to at least go read the first 4 pages of the executive summary, and we can post this let's
put a link in the put a link in the description, and
at least read the first 4 pages of the executive summary. But let's go through those.
It looks like this. So if you see my camera, it's just these PDF documents. It's the 3 bullet pointed things. Starts on page 16.
It's easy. The first one, they want to do some changes to insulin, as you guys all know.
Let's talk about. I mean, the first one, you already said the word, the V word. Vaccines.
Well, let's get there because that's later on. That's
provision number 1, right?
No, I don't think so.
Yeah.
Well,
it's provision number 1.
All right. Well, I read about 25 pages of it, and I needed to have a heavy drink to get through it because it was painful to even read through 20-something pages about them. I don't know if I get flagged on YouTube and censored for saying vaccine or not, but I don't know how you talk about
vaccine. You do. I'll tell you.
I don't know how we even talk about a CMS call letter in an industry we're in when literally it's like, hey, here's how they're covered or not covered and what the cost sharing is. So anyways, whatever. You're going to have to watch this episode on X.
I just bring it up because I think it's interesting that that's the number 1 provision thing they talked about. And, if you're following what's going on and you know who the incoming head of HHS is, you kind of know, that individual's opinion on the vaccine and the vaccine schedule. And so it's almost like there's a lot of gamesmanship that goes on, especially with, I feel like, dropping out this call letter, and whether they know that a lot of it's going to be actually implemented or ingested or there's a lot of we tried to do this, but then.
Well, I think like anything, the person coming into office is on this end of the spectrum of their opinion of that. And where they're over here, they want to go as far an extreme here so that they can hopefully meet in the middle, right? I feel like it's almost anything. They want there to be some can I say bipartisanship? I don't know.
Yeah.
They want there to be some bipartisanship and maybe land somewhere in the middle, right, is what I'm perceiving or think. But, the biggest thing is there was a lot of language about definition, and of course that they they mentioned that there is an advisory committee on immunization practices, and that they use that ACIP acronym a lot, and that they're basically going to make recommendations. They're going to change what is approved or not approved. The crux of it is really that any vaccine that's recommended by them and by the director of the CDC will get approved, and essentially that's not subject to deductibles, and it will be a zero copay. In MA organizations.
But yet it also says there's no financial impact to that. So
we're going to go that table where we're going to go through individually. But so
how do you do that math?
Overall, they're basically saying that any vaccines that become essentially recommended by the ACIP and the CDC director are going to be approved, and that MA organizations are going to approve them. And if there's changes throughout the calendar year that meet that criteria, then they would also be covered at no cost share to a beneficiary, which of course it's going to broaden a lot of them. It also said that there's different categories right now on vaccines, which include routine catch-up, risk-based, and shared clinical decision-making recommendations. That basically there's other decisions to vaccinate an individual based on their age, other indications, etc. Even travel. So if you're going to do a foreign country and there's certain things that aren't even part of routine, but it's recommended for your travel, all those are now going to be approved. And anyways, so it's kind of, in my opinion, the way I interpreted, and if I'm wrong, somebody tell me I was, but I interpreted that with more expanded vaccine availability.
Same.
And more vaccines
added to the schedule under the advisory committee.
To the schedule and covered at no cost to consumers, which in my opinion is of course going to boost the number overall of vaccines, and I think was a big bone to throw into the pharma companies.
Correct, which would have a cost, but yet this says there's no...
Well, we're going to go through that table in a minute individually, so we're just going through each paragraph. So that was the first thing was vaccines was on there. Another thing which was, pharma related was the insulins. And those meds, of course, as you know, have been capped at $35 copay. They've just changed it to kind of say it's going to be the lesser of three, either the $35, 25% of the max price, or 25% of the negotiated price. Whichever is the lesser is what the beneficiary is going to pay. So in some formularies, I don't think it's the 25% of the max price, but sometimes the PBM and the carrier, they have a very, very low negotiated price. So I think that 25% of the negotiated price is going to be a lower copay for some people on their plans. And so that's when you even go through like the CBO, like the projections of, will this cost the Medicare Trust Fund anything? The answer is yes, because there is a little bit more subsidy going into insulins.
Well, whoever did the financial impact on this, I should hire them to do my taxes.
I'm going to throw my hat in the ring there and say I might be qualified.
Because I'm like, wow, those you're sure where'd you get those estimates from? Those are very
they're not as good as my napkin math. When I have Mike and I joke about napkin math, because whenever I like go to forecast like hiring a W-2 or their comp plan or our spend or what we're doing with co-op dollars or our ROI, what our CPAs are, when I kind of start crunching some preliminary numbers, I call it my napkin math. And then I go, typically have the numbers verified by our financial controller. We're usually pretty freaking close.
Our napkin math's way more accurate than this. I can just tell you.
That's what I'm saying. Like way better than this. And anyways, the other thing that I am just going to say, as reading through already in the executive summary, is you all listening are probably now familiar with the Inflation Reduction Act and the smoothing process, on Part D and
or M3P plans.
Yeah. So now there's the prescription payment PPP, the prescription. Not to be confused with the TPP, the PPP. And
or PPP loans from during COVID.
If you're down with the TPP, if you know the Between Two Ferns reference I'm talking about, are you down with the TPP?
Yeah.
I think that people deserve to know, are you down with TPP?
I'm not down with TPP.
No, you're supposed to say, yeah, you know me. Like the hip hop group.
Don't tell me what to say.
Anyways, the prescription payment plan, it's now going to be a required document in all plan materials to consumers, where they have to, kind of like STARS information is required. They're going to have to give more information about the prescription payment plan availability to all consumers, make it very prominent on websites, on marketing materials. So of course, what is that going to do?
It's going to make it more complicated, more cost effective, more cost prohibitive.
It's going to have a lot more consumers raising their hands saying,
"Oh, I want to do that." Yeah,
I have expensive drug costs, and I want my insurance company to absorb all that cost on the beginning of the year and then standardize my payments throughout the year. Of course, I want that. Well, when you have a 25, 35, 50% uptick in people doing that, that puts capital restrictions and stress on the carrier too. So I'm just telling you, CMS and the Medicare Trust Fund may say we don't care about that, but the real implications in business is that puts financial strain on those carriers. So
well, not only that, but this year we had almost all the carriers, if not all the carriers, opt into that demonstration period.
Yep.
And this does nothing to address the demonstration period or the future financial impact to that.
Inflation
all
reduction.
It does is it goes to say, and we're going to make you spend more money to tell people that you have to foot the bill for the smoothing process too.
And have it be an interest-free bank for them. So anyways, again, we haven't read through the entire call letter, so maybe there's more in there about smoothing and the Inflation Reduction Act. We'll update our episode next week. But the other thing, this one, like, I was on a tear earlier today about this one, the semi-glutides, and adding in all of the as they call it, the AOMs. This is the new acronym, everybody. The anti-obesity medications. So this is going to be your Ozempics. For anybody who hasn't watched the latest South Park special about it, what was it called? The End of Obesity.
Yeah,
it was pretty funny. It was pretty awesome.
Yeah.
But so kind of going into right now, I don't know the name. I only know like Ozempic. What are all the other
Monjaro?
Yeah, there's a bunch of them. They have the
tirzepatide,
the worst commercials on TV. I will tell you that. But anyways,
Jardiance.
Oh yeah.
The Jardiance. I'm lowering my A1C. It's always so easy.
Those jingles are really
It's just
bad.
so nice and easy to just not be obese. Just a shot or a pill and a dance.
Don't make life choices like exercise and just take a pill. Anyways, look, I'm not trying to offend people out there who are on it. I'm just saying they're saying that they want to redefine and reevaluate some of the statutes and determinations because right now, as it's written, like weight management and weight loss drugs are not typically required to be in formulary with Part D plans or with Medicaid. And they're trying to reevaluate the definitions to include them and have them be in formularies. And instead of it having to be, something that is MAI, which means a medically accepted indication, that's what's needed right now to have somebody get on that or have it approved by insurance. They're trying to waive that and basically say that anything that is weight loss for like chronic weight management is going to be basically in formulary. So, I mean, I'm just thinking of like the cost of suddenly having everybody nationwide who is obese on Medicaid and then also, on Medicare suddenly have access to these drugs, just what that's going to do to, coverage costs. I mean, just on the Part D, just the billions and billions of dollars.
Well, these things are famously expensive, right? And everybody knows that, which is you referenced the South Park episode, why they say rich people get Ozempic and poor people get Lizzo.
Who, by the way, is now, did you see the pictures? She's been on all those drugs now, and now Lizzo is skinny.
I don't know. She's not on my algorithm. I don't have any idea.
How ironic.
You look at this financial impact here, and it talks about there being a $25 billion potential impact to Medicare and 15 to Medicaid.
And I go times 2 on all
times
these.
10. But it depends on the study you've seen, but I've seen, industry projections that would be much more expensive than that. And look, I get it from a standpoint of health. Obesity is one of the number one causes of metabolic health, chronic conditions, and early death in this country. And, if you can solve the obesity crisis, then it's going to massively lower the overall burden and cost of treating the system. I just don't know, if it's all easy to do it through these, these things definitely help. Obviously, they're getting a lot of results. It's just going to be tremendously expensive. Right. And I don't know that it's the be-all, end-all solution that we need. Well,
and I'm not like just for anybody who's listening and maybe people are like, yeah, I totally agree or Dan's wrong or whatever. But I just, I'm not like the how should I put it, the authoritative figure on any of that. But I will say, a lot of those meds have a lot of side effects. And on the one hand, you go, well, if someone stays really obese, they're going to die of heart attack, heart disease,
correct,
high blood pressure, whatever else anyway. Or you could take these meds and then you have all these other side effects. It's like, they were going to die anyway, get diabetes or get all these other conditions and die anyway. So,
well, it's that risk arbitrage, right? And I think overall, that's what, we're saying is, there's risks to these medications, but it's much less than if you remain,
healthy,
massively obese for.
I'm on the other side of things where, the food is medicine is more where I kind of align personally and go, well, what you put into you, good in, good out, lifestyle choices, X, Y, Z.
Yeah, but we're definitely going to have way more success getting people to take a magic, or at least a helpful shot
eating broccoli
than we are.
I know. I know, but I'm just saying, so that's a whole stick a pin in it. That's a topic for another day.
We really need a food as medicine expert to come on and talk in like a future of healthcare. I think
we really could, but
if you're an expert in that field and you want to come out on the podcast, hit us up.
Anyways, so that was one big thing. Cause immediately when I started reading about, basically ingesting or having all those GLP-1s in
but the cost projection, I give that 3 Pinocchios.
Dude,
yeah,
way wrong. So that's a big thing. Cause I'm just already looking at the system, like the whole system and supply chain of plan design this year and nerfed benefits and reduced things and reduced commissions. And I go, oh boy, I'm sure all these carriers are going to just absorb billions more in all these GLP-1 costs, especially now with the Inflation Reduction Act where they're capped at $2,000. How does that work? I can't.
Well, and especially you've got the, the pharmaceutical companies who are, at least conceptually going to be under some pressure for financial and other regulatory things, and this would be a windfall for them if they're able to really maximize and basically offer these to everybody. That would be interesting to see how that all plays out.
Well, look at the two biggest segments of healthcare. Look at Medicare and Medicaid, and you get it through both of them, and you got it through. Now your customer base is just 10x or more. You know what I mean? So anyways, that's a whole other thing. I could talk about that for a whole episode, and I'm going to try to not, because we got to get all these points. The other thing, enhancing plan data from carriers to CMS on the Medicare Plan Finder. One of the things they want to start doing is, I get adding in the linguistic capabilities. I think that's actually a good thing to put in the Medicare Plan Finder if somebody's bilingual, like Spanish or Vietnamese or Tagalog or whatever else, especially for people who have a language barrier. They're going to be more comfortable going to a physician where they speak their native language. And especially when you're talking like medical terms and diagnosis and things, I think that makes a lot of sense. Where I don't know that I agree with, and I haven't read all the cultural capabilities, but they've also added an element in there where they expect the carrier to provide CMS with like cultural capabilities at physicians, which I guess I'm going to dig into later in the call letter and read about very specifically.
It'll be interesting to see. We don't want to go have things be too much into like identity type politics and things like that, but there's definitely, we both sat at the kitchen table belly to belly with people, and you definitely have beneficiaries who have a preference of like, I want a female or a male doctor, or a doctor that's of this ethnicity or that, because they're, going to understand me from a a cultural perspective or an
So a couple of things though, just so people understand it. That's I get that.
It's just
I get
hard to like.
Well, then
how do you describe and quantify that?
So again, that doesn't cost the Medicare Trust Fund anything. But if you're an insurance provider, let's see, you're a Molina, you're a Centene, you're a Humana, and now suddenly you have to now enrich all of your provider data and go across like every single network that you have nationwide with every single provider and every single NPI, and start enriching their profiles and adding all these other elements. That's not free. That costs you millions and millions of dollars to do that across your entire organization to provide that enriched data to CMS. So I'm just telling people from a business perspective, there are those hidden costs where something sounds good, but in practice, it costs a lot of money to do those things.
Yep.
So just that's...
Yeah, and I mean, it'll be interesting to see how that all plays out. I'll have to read into the details of that.
Yeah, the other thing is, this is one that I am calling some hot, steaming BS on because it's very vague. I don't like vagues, and guess what? If anybody's learned anything from the lawsuits this year, you can't write things and be vague and then be like, well, we intended this. And it's like, well, if you intended that, you needed to write that very clearly in English so that carriers and people could interpret it. That's hence a lot of these lawsuits that are going on right now. But some of the language was require agents to discuss extra help and Medicare savings program.
Yeah, there's two things related to this. Promoting informed choice.
Well, promoting informed choice with first-time enrollees to Advantage, or when dropping a supplement, info on Medigap guarantee issue. General information on original Medicare versus Medicare Advantage. Well, what is that general information? It wasn't very clear in there. I guess I'm going to read more about it. And then also require a pause before proceeding with an enrollment or addressing questions. So I'm just going like, FML. Okay, so this is going to be me at a kitchen table being like, okay, consumer Mike, here's all the differences between Advantage and Supplement and all these things. And I did a whole needs analysis. Here's your presentation. Now, I'm going to pause. Let me do this specified pause for this time period. Think about it. Is it like, am I going to read in the call letter that there's some time? Is it 30 seconds? Do I have to like stare into their eyes and go, you sure you don't have any questions for me?
Yeah.
I gave you a lot of information. You sure you don't want to sink this deal? And like,
after you just talked to them about how Medicare works, how the difference between Medicare and Advantage, inform them of their federally guaranteed Medigap rights, their possible low-income subsidy that they may or may not qualify, their blah, 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 blah. Then pause and go.
If the people writing this have never done sales, because usually you go through like an entire sales process anyway, where if you're doing any kind of a good process, you're asking the right find out questions, you're going through a needs analysis, you're doing solution-based selling, you're identifying what's important to them. And then when you go to give them your recommendation, you already address all their concerns and you're asking them for any questions or concerns, and you go for a close to vet out and flush out if there are any like objections or things like lingering around that are going to prevent them from wanting to choose the product. Like that's a normal sales process.
Well, not only that, but one of the value of the agents is to almost, not necessarily filter out information and only apply to what needs, but a little bit, there is some of that, there's so much, tax code, and there's so much information surrounding Medicare and these plans that consumers are already so confused about. And a lot of times when you give them this information overload, they get this analysis paralysis. And what they're looking to you as a trusted advisor and fiduciary is for them to understand their situation, make recommendations, explain their options to them in a cohesive, concise way, and give them guidance as to what you should do. And this is my whole thing with CMS overall, is it's like, we as agents, you already have a professional license. I've talked about this before. You already have a legal, ethical, and moral fiduciary duty to act in the best way for your clients and perform those duties. And so all we're trying to do is legalese and introduce all of this very detailed minutia that agents are already supposed to be acting by and already supposed to be performing by, but yet we're trying to codify it and really spell it out in these very specific bullet points.
Except for in the next section where you're not supposed to, and it's going to be gray.
Yeah. Which is the second part
hold
of
on.
the...
Well, going back to that, so here's the other thing. Going back to this whole, and here's why I take issue with it. If I'm an agent and I roll up to a certain zip code and I drive into a neighborhood and I roll up to a $2.3 million house, I don't probably need to ask them about the Medicare savings program and seeing if they qualify for extra help. If, I meet with them and they're wearing a Rolex or something else, they're probably not going to qualify for the Medicare savings program. And am I going to be required to go through that and do disclaimers and spend time educating them about
Check the box
when it's not applicable? Or by the other thing, do I really need to talk to somebody in a trailer park on Medicaid about GI with MedSup? Probably not. So it's just, there's a lot of those things that when you become a good broker, you do intentionally filter some of those things out and you give people the applicable information for them to make good informed decisions, but it doesn't need
that are applicable to them.
So anyways, so this is just more where I, from a practicality perspective, don't like some of the things I'm already seeing because I'm already getting triggered thinking about all these new disclaimers and steps and check boxes that we'd have to do in the sales process that may not apply. The next thing was on the marketing and communications, where we're going through right now as is, there's very specific things that classify something to be marketing or sales related. So if a broker, of course, makes a piece talking about star ratings, that's talking about a plan specifically that's sales and marketing. If you start talking about co-payment amounts, premiums, extra benefits, that's criteria that makes something and classifies it as a sales and marketing piece. I like that. So again, going back to, if the criteria is X, that means it's sales and marketing. If it doesn't, then it's a general communication.
Or educational,
yeah, that makes sense. And so I don't like that now in the call letter, they're saying that they want to broaden their ability for compliance. And so therefore they want to remove specific criteria, which again, this is what gets people gets everything into trouble. And they want to make it more vague to where everything is just based on interpretation of intent. Well, if you take away all that to where you kind of go, now we already can't even get carriers to agree on certain pieces, right? When we have, let's say, 9 insurance carriers, or MAOs, as CMS likes to call them, the Medicare Advantage organizations, and you go to an MAO and say, hey, insurance company, here's this marketing piece we're going to run with, you'll get 7 of them to opt into it and say, yep, we opt into that, go ahead and use it, approved. 2 of them are like, nope, we don't want to opt into that. Why? All these other 7 did. Well, this is just how we interpret it. Can you give me more specifics? Because the other 7 didn't, and you're outliers. Our compliance person didn't like it. Can you tell me what they didn't like? No, it just didn't get approved.
Yeah.
Okay, so this is kind of the process we're already going through as a large distributor and when we try to make marketing pieces. So if you remove some of that very specific criteria that makes something marketing or not, and you just leave it vague to open to interpretation on intent, it is going to be a total shit show getting anybody to agree on anything.
Well, and who's the arbiter of what's going to be decided? You're basically purposely making everything subjective, right? And again, here's the other thing, speaking to the camera, talking to CMS directly, I'll just give you a preview. Everything is marketing. in some way, shape, or form. People that put out educational events, people that put out educational content and brand it as an educational event, people that put out helpful content. It's all breadcrumbing and dripping out educational content for the ultimate purpose of either building a following, building trust, or ultimately marketing to those individuals.
Direct or
indirect. And that's all it is it's like anybody that's putting out any sort of graphic, any sort of info, any sort of educational piece, any sort of direct solicitation, any sort of advertising of benefits, it's all marketing. And ultimately, it's all leading towards the intent of trying to let a beneficiary know that you may be able to help them with their insurance, either directly or indirectly. And so this trying to parse out and delineate all these separate different things is just so useless and just causes so much more confusion than necessary, because at the end of the day, that's what all these carriers are trying to do. That's what all these brokers are trying to do, is they're trying to promote themselves. They're trying to get in front of consumers, and they're trying to basically let them know that they could be a good resource to help them with their informed, Medicare or ACA health choices.
And of course, a lot of organizations and agents have done that because of all the other marketing restrictions that are already out there and already exist, right? Mm-hmm. And so that's one of the few avenues that people have to actually grow their following and continue to grow their business. So anyways, we have done a poor job of being able to timely get through all this because we're like coming up on time, and I got fired up on a couple things, but we don't even have enough time to even scratch the surface really. But before we wrap, so I really, really, really already just in the executive summary don't like that part about the marketing and communications and removing specifics and going back to intent. It just is too vague and too gray for me. Also, there was a mention, which I'm sure I'll dig into this weekend, on the limited income newly eligible transition, the LI-NET program, which is new. Don't know about that, but I'm throwing that out there so that everybody on the interwebs can start researching and figuring it out like I will. One thing that I did think makes sense is they put out there that, PBMs, they're negotiating particular drugs and also preferred pharmacies and non-preferred. And you'll find when you're selling PDP plans or MAPDs, frequently there's a preferred pharmacy, like, hey, this particular company uses Walgreens as a preferred, or this one uses CVS, or, sometimes you'll get better pricing at a preferred pharmacy, or they're in network or out of network. And so I think that they did put in there that PBMs need to notify which pharmacies are going to be in net or preferred before 10/1. So going into the sales season, I do think that actually makes sense so that you're not out there as a broker communicating like, hey, the preferred thing with this plan is Walgreens, October 13th. And then in December, it's like, just kidding. You now have to change to this other pharmacy network or something else. I think that actually makes sense. So that was one thing in the executive summary that I got out of there. The other kind of thing is the Flex card. There is a lot of information about cracking down on, well, they called it debit card benefits, right? Mm-hmm. But I always call it Flex cards, spendables, whatever you want to call it. What does UHC call it again? Flex card, right? Or what do they? Anyways, just about every carrier out there has extra benefits, ancillary benefits now attached to a debit card or a Flex card for people to spend, whether it's for groceries, whether that's for OTC, over-the-counter materials, whether that's for dental or vision. And so there's going to be a lot more disclosures and disclaimers that are required around those extra benefits on the debit cards. Then there's also requirements to where if there's an issue accepting the debit card, there has to be an alternative method to being able to use that benefit. And then they also said that there has to be some kind of a real-time link of kind of like that purse or what's available in that debit card with the plan benefit. And it can't just be like some vague thing where you swipe it and you're hoping that it works. It has to have some mechanism to really have a real-time view into what benefits are available with your particular plan. And again, more clarity on what OTC items are accepted. And obviously, this is something that I thought was hilarious and comical, I'm just going to say. They put a note in there that they want to prohibit insurance plans or MAOs from marketing the dollar amounts of those supplemental benefits. And I'm like, what do you, and
Why?
how it's administered. And so again, going, sorry, if you're open for comment or accepting any, my comment is that is absurd. That's like saying, hey, this plan's really good. Trust me, wink, wink. I can't tell you the dollar amounts, or I can't give you collateral or advertising about how much is on dental or how much is available through grocery or whatever else, but they want to prohibit the amounts on the supplemental benefits available. And again, going back to the mechanism, I'll be honest with you, this is something that people at carriers and CMS don't understand. When you have a really good vendor and it's a frictionless process and you can access your benefits really well, sometimes if that mechanism to access your benefits is really smooth, I personally would take a $500 benefit that is seamless, easy, great, over a $1,000 benefit all day long. If it's a pain in the ass,
you have to jump through hoops.
Yeah, if you got to go through a reimbursement process, if you have to, submit your claim, if you got to wait 60 days, I'm going to pick the smaller amount that's really easy. And a lot of consumers that same way. So to say that you can't advertise the methodology of how to access those benefits, I think that's also absurd. So anyways, we're like at time, and we're
over. I mean, we'll have to do a part 2 and a deeper dive on this, because it's going to be, people are going to really be interested. And I do think overall, and this is just what I'm hoping for with a new administration, is the intent is good on a lot of these things, right? I don't think anybody discredits that. It's the administration and the oversight and the regulation. You don't need to codify every single thing and make all these little annoyances and all of these friction points, because guess what? You get to the point where it's been this last year and in the last 2 years, where it actually has the opposite effect. When you sit down with a beneficiary and you go over these things and you say some of these disclaimers and you read some of these things, it doesn't engender trust. It's like, why are you saying this stuff? Like, why? Like, they already
are you scamming me?
Yeah,
like
is that why you're having to doesn't have
yourself?
The intended effect, and it just makes it overly complicates things so much and causes so many more friction points, that I'm hoping that we can really start, unwinding some of these things and get back to operate, the industry having some facet of trust that the fiduciaries, the brokers, the carriers were operating for the good of the beneficiaries together, and then we can all together root out those who are not doing things the right way, the fraudsters, the actual people who are not doing things correct, and
right.
That's how it's always been. And I just hope that we don't have to overly explain and codify and put all these long disclosures into everything that ultimately don't have the intended effect that they were hoping for.
Yep. And to wrap on this episode, I think I'm going to attempt to shoot part 2 today, because we'll see if I can.
I have a dentist appointment, so I got to go.
Just cancel for the 3rd time. I'm just kidding. But no, the one thing I do want to comment on too is there's a lot more. Like I said, we haven't scratched the surface, but my biggest thing whenever I read these, just so everybody knows, is as a business owner, I always look at the hard cost and then like the indirect or the hidden cost to everything. And my biggest theme of all this is, even while these all have great intentions of, I think it'd be great to cover, medications for people who are obese and help them be healthier. I think it'd be great to, mental health is something we'll go into here later in part 2. There's all these other things that they all sound great. Providing long-term care for everybody would be great. Providing, you can go in, but where do you draw the line on what you cover? Because at the same time, all these well-intended things that they have, and we'll go through the table of what the CBO thinks will cost the Medicare Trust Fund. While it may not cost the Medicare Trust Fund anything, you can't simultaneously fund the payers or the insurance carriers less dollars and then also make things more cumbersome, require more of them, increase the administrative expenses and everything without having impacts. And I'm just looking at all those hidden costs of a lot of these implementations, what that's going to do to these carriers. I know the way they operate. They need to be profitable. And what they're going to continue to do, if these all get implemented, the end result in the supply chain is going to be very, very, very ugly for the small agents and the agencies out there, ultimately.
Well, and like we talked about, when we're having to jump through all these hoops and the carriers are having to jump through all these hoops, you're just spending time on the wrong activities. You're spending time being in compliance with things that don't give consumers better care. They don't give consumers better choice. They don't make it easier for them. And let us get back to doing that. That's, and the carriers can focus and reinvest their dollars into providing good experiences and good benefits and being insurers. There's one more thing that I don't want to, that we'll have to tease.
I was going to say, I was going to preview the 4 or 5 other things for part 2.
Well, I was going to talk about how they dripped in there about the vertical integration for the
last sentence there. The vertical integration, addressing that
with the MLRs. Yeah.
Yep. MLRs and compensation formulas to the carriers.
That's a big one. That was probably one of the main things that we didn't get to today.
The numerator is going to be smaller, which is meaning that there's going to be less excess payments to carriers. Mental health will need to be covered, and essentially, anyway. So preview for next. More on the duals with integrated cards, MLRs, more on vaccines. Again, more on PBMs, health equity, AI.
We got
used in healthcare. So there's a lot more that we need to cover in episode 2. Dang it, we can probably do 5 episodes on the call letter. But
okay, well, we're out for this one.
Okay, man.
Catch you guys. Thanks.